I'm Phil Zeitler. I'm an endocrinologist at the University of Colorado. I wish I had some bears. I wish I had thought of that, because I have even less to say than you did, wherever she went. Oh, there you are. I like it. I wish, if I had thought of the bears, yeah, I need a few more of those. Anyway, there is really very little published information on the prevalence of endocrine problems following hemispherectomy or other large epilepsy surgeries. And so really what I'm going to talk about is based on some limited clinical experience and consideration of the potential problems that could occur in this circumstance, mostly based on hydrocephalus in other circumstances. Just to remind everybody, why is this even an issue? The hypothalamus and pituitary gland are located here at the base of the medial forebrain, so they are in an extremely vulnerable position. In addition, they are highly connected. So the hypothalamus is highly connected with, if you will, higher CNS centers. So people used to think of the pituitary as being the master gland, but it's not. It's really just a hormone producer. So then people started thinking, well, the pituitary is regulated by the hypothalamus, this little area sitting up here. Now we really understand that, in fact, the hypothalamus is, to some extent, only a transit center for signaling, and all of this is regulated by higher centers. So this is located in a high-risk spot. It's highly connected to higher centers, and it is then based on its stimulation from the hypothalamus, delivering hormones into the peripheral circulation where it regulates a number of processes. I sort of think about the pituitary as kind of the Amazon.com of hormones. It is a storage center that is then delivering things under regulation. It's involved in a number of processes. Growth hormone is made that regulates growth. Thyroid stimulating hormone regulates thyroid, which involves metabolism as well as gene expression in many tissues. ACTH regulates cortisol and the stress hormone system. Prolactin is involved in lactation. We tend not to worry about it so much, except it can become elevated when the central nervous system is disrupted. And we have the gonadotropins that regulate the onset of puberty. In addition, in the posterior, pituitary is not showing on the, oh, here we go again. Could you advance that? The back part of the pituitary is also involved in production of a hormone called vasopressin, which regulates water reabsorption at the kidney. Is it going to work? Nope. Okay. So much for animations. Oh. Another one. There we go. All right, so what kind of problems can occur? What is the impact of similar clinical circumstances? For surgery, what we often see, and the most relevant would be basal forebrain tumors and resections. We see anterior pituitary deficiency. Oh, these are in different places on this one here. And this one doesn't have a pointer. Okay, we see anterior pituitary deficiencies. We can see diabetes insipidus that Monica talked about, which is a problem with a water balance, but you can also get thirst dysregulation. So it's not just water. There's also abnormalities in thirst. You can see excessive appetite, as well as abnormalities in energy expenditure and energy compartmentalization. So it's not just that the kids eat too much and when they gain weight, but there's actually abnormalities in the way energy is being used. You can see temper dysregulation. You can see dysautonomia. You can see behavioral disorders that are quite typical of hypothalamic abnormalities. What do we see with hydrocephalus? Typically, precocious puberty and abnormalities in appetite regulation, energy expenditure, and development of obesity. So what about diabetes insipidus? This is a deficiency of a hormone called arginine vasopressin, sometimes known as antidiuretic hormone. It is released in response to decreased blood volume normally. It increases reabsorption of water in the kidney, and it increases thirst. Whoa. It is frequently disrupted after central nervous system surgery, and you can get abnormalities in production of AVP so that you lose water, you become severely the sodium rises rapidly in the blood, you lose blood volume. You can actually also see the opposite, where excess AVP is made, the body hangs on to water inappropriately, and you get expansion of blood volume and a drop in sodium, which leads to seizures. This is a frequent cause of management problems following surgery, but is for the most part transient, but not always. Pubertal abnormalities with CNS tumors. Less common, you see decreased function. This can look as either delayed or arrested puberty. Rarely do you see complete absence of puberty. You can see menstrual irregularities, either immediate or later onset in women. But it's really sensitive. More commonly, interestingly, is you see premature or truly precocious puberty, or puberty that starts on time but goes very rapidly, which we call early rapid puberty. The mechanisms behind this remain unknown. The way we think about it is that the system is actually active at the time of birth. Little boys at 1 month of age have testosterone levels that rival those of adult men. The whole system is shut down by higher centers. Hand waving happens now. Anything that disrupts higher centers can lead to onset of puberty. And that's about as well as we understand this. So you see early puberty in any kind of central nervous system disruption. Epilepsy without surgery. You see it even in kids with developmental disorders. You see it in kids who've had any kind of spina bifida, etc. So we don't know what this. Kisspeptin is a neuron that's been implicated, but we now don't know what it regulates it. So it's sort of slowly moving up, but we don't understand. There's actually very little even in hydrocephalus, although this is well known clinically. I was able to go back and find the original report of accelerated puberty in hydrocephalus. 114 patients compared to 73 healthy controls, age 50 to 20. Testicular and in boys and male and female pubic hair development occurred significantly earlier in the hydrocephalus patients. The mean age at first period was lower in the patients than the controls and lower than their mothers, so it's not just a genetic thing. Testicular volume was higher in the male patients at all ages, and the prepubertal patients had higher hormone levels, suggesting that the system was activating. So the authors concluded that accelerated pubertal maturation may result in variations from intracranial pressure. This is back in 1996. I really didn't find much after this. Very little has been done. Oh, this is like a double every time. There we go. Yeah. Adrenal insufficiency. ACTH is regulated by CRF from the hypothalamus under the influence of higher CNS centers that respond to anxiety, fear, physiologic stress, etc. Double. Prevalence of adrenal insufficiency following hemispherectomy is unknown, but is increased in hydrocephalus and other sorts of midbrain surgery. The symptoms acutely look like low blood pressure, low blood sugar, or shock. Chronically, difficult to discern, reduced energy, appetite, stamina, and low blood sugar. It can be life-threatening if unrecognized during illness, but we do not have any idea how prevalent this problem really is. Growth hormone is regulated by two hormones from the hypothalamus called GHRH and somatostatin. GH secretion is highly vulnerable to disruption. That makes sense. If there's a problem in the brain, the last thing you need to worry about is growing, right? So it tends to be one of the more fragile of all the hormones. The symptoms are poor growth, decreased muscle mass, increased fat, and fatigue. TSH is regulated by TRH and somatostatin from the hypothalamus. TSH secretion is moderately vulnerable to disruption. It tends to be the sort of second hormone to get hit in these kind of situations. It's really frustrating. Symptoms are poor growth, increased fat, fatigue, and decreased metabolic rate. What about hypothalamic obesity? This is a kid, actually, we just saw. I don't know how well you can see this, but if this is a BMI chart, and what you see is this child's BMI had surgery. It wasn't epilepsy surgery, but it was a surgery of a different kind. Straight up. Body mass index, straight up. Remarkable, and this is not unusual. So it's a dramatic problem in craniopharyngiomas and other hypothalamic tumors, and it's been reported by families of kids with epilepsy surgery. Hypothalamic obesity is severe and it's difficult to treat. The etiology is not well understood, but there is important role of central nervous system regulation of appetite, changes in metabolic rate, reduced energy expenditure and activity level, and abnormal appetite regulation. And why would that be? Because, you won't be surprised to hear, is that the appetite resides in the hypothalamus. And I won't go through this, but there's actually quite a good understanding now of the neurons that are involved in the regulation of appetite and in the integration of peripheral signals about whether you've eaten or not eaten or how much fat you have are all being integrated in the hypothalamus and leading both to appetite and the way that you burn calories. So it's not surprising that disruption of the hypothalamus would lead to obesity. So what is specifically known about endocrine problems after epilepsy surgery? I need the bears now. Epilepsy surgery, sex hormones, and the menstrual cycle. This is a study from 2000, 16 female patients with temporal lobe epilepsy investigated prior to surgery and then subsequently. There were no significant differences between pre-surgical and post-surgical concentrations of androgens, male hormones, prolactin, growth hormone, or cortisol. 4 patients had a change in menstrual periodicity. 2 developed regular cycles who hadn't before, and 2 developed abnormal cycles who had regular cycles before. We've now covered the literature on endocrine problems post-surgery. This is a slightly different situation. These are children who had surgery for hypothalamic hamartoma because of endocrine problems and seizures. These patients can have seizures, but also often have precocious puberty to start with. It's a somewhat different situation. And in these patients, 45% had central precocious puberty at presentation, and the surgery didn't cure that. Free thyroxine or thyroid hormone levels fell after surgery in the majority and became clinically significant in 5 of the 29. Low growth hormone was present in 5 of the 8 patients who had had a prior surgery and in 6 of 29 who had not, who underwent surgery here. Hyponatremia, in other words, at least transient diabetes insipidus, occurred in most patients postoperatively with sodium greater than 150 in about 55% of these kids. They're mostly kids. No patient required ongoing hormone replacement postoperatively. And appetite stimulation and early postoperative weight gain occurred in 45%. Now they said, oh, it's great, it resolved in half, but that means 30% had ongoing problems with obesity and appetite problems. So in summary, individuals undergoing large CNS surgery are at risk for development of hypothalamic pituitary dysfunction, diabetes insipidus, precocious puberty, for sure. perhaps adrenal insufficiency. Growth hormone deficiency would be expected, but not well reported. TSH deficiency would be expected, and hypothalamic obesity would clearly be expected, and it sounds like the families are reporting this. The incidence and prevalence of these problems in this particular population has really had limited study. Hypothalamic pituitary abnormalities can result in significant morbidity and reduced quality of life for these patients if unrecognized, and therefore we need more routine endocrine assessment in these kids. Thank you.
All right, so I'm going to be speaking about hydrocephalus after hemispheric surgery and other large operations. It generally doesn't apply to surgeries outside of hemispherectomy. I personally haven't seen it. I'm sure there are cases out there of other large resections, but it's commonly associated with hemispherectomies. Okay, so briefly, I'm going to review cerebrospinal fluid or brain fluid physiology. What do we know about post-hemispherectomy hydrocephalus? And what do we need to know about post-hemispherectomy hydrocephalus? So everyone makes brain fluid every hour. It's made primarily in the choroid plexus, although there's other sources as well. That's the tissue in red in the middle of the head. And it's primarily absorbed at the surface of the brain at the arachnoid villi, but there's other places of absorption as well. And for each drop of brain fluid that's made, the same amount needs to be absorbed. And if it doesn't, then you have a problem. You have hydrocephalus. Very briefly, the skull is a closed space, and if there's anything that takes up more room, either a tumor or whatever it is, including hydrocephalus, can press on the brain. And over time, if there's more and more pressure, it can cause a life-threatening problem and concerns for herniation. That's when the brain squeezes into the spinal canal, and that can be fatal. That is fatal. So hydrocephalus is really an imbalance between the production and absorption of brain fluid, and it may or may not present with a change in the ventricular size. And that's important to know, just so an MRI by itself can't completely rule it out. There is no cure. It's a lifelong condition. So I always talk about if you can treat the child's epilepsy, which is a lifelong condition, but if you leave them with hydrocephalus, that's another lifelong condition. You've swapped them epilepsy for hydrocephalus, and hydrocephalus is also quite dangerous to live with. And the only effective treatments are surgical. So what causes hydrocephalus? On a fundamental level, you can have increased brain fluid production, which is actually quite rare. You can have impaired absorption, or you can have obstruction in the fluid pathways. Now, each one of these three can really happen post-hemispherectomy. Surgery often induces an inflammatory process and can sometimes increase the amount of brain fluid being made, at least temporarily. Blood and protein can obstruct CSF absorption at the level of the arachnoid villi, which I showed. And also disconnecting brain areas from one another can also affect CSF flow dynamics. So you can really have any one of these in a child that develops hydrocephalus. Now, these kids end up in the emergency room quite often. Anyone who's had a child with hydrocephalus knows that it's usually in the middle of the night, your kid's sick, vomiting, you're not sure, is it the shunt or not? And shunt problems manifest in three flavors. One is the child that obviously has something else going on. They have gastroenteritis or they have flu symptoms, and the ventricles look pretty stable from before, and that's not a shunt problem. That's easy to diagnose. You also have the child who's projectile vomiting multiple times, retching, comatose, with acutely enlarged ventricles, and that's easy to diagnose too. That's a shunt problem. You go into the OR, you fix it. But often you get this, where you have a child who is maybe having some headaches. The MRI doesn't show anything. Nuclear studies don't show anything. Shunt taps look okay. Or maybe they just have some behavioral changes. And this is the more common thing that we deal with, and as you can imagine, the amount of frustration that is associated with. I think it's out of battery. Oh no, there we go. So the evolution of hemispherectomy surgery has gone from anatomical approaches down to now the endoscopic assisted hemispherotomy, and all of this was really done to decrease the morbidity associated with hemispheric surgery, which in general, the less brain tissue that's removed, there's less blood loss during surgery, less likelihood of developing hydrocephalus. At least that's conceptual. A few facts. The most common way we treat hydrocephalus, although it's not the exclusive way we do it, is with Csf Shunts. These are permanent implantable devices in the body, and you become permanently dependent on it. Technology that's been around since the 1950s, and very little progress has been made. Permanent dependence on this device. This device has the highest failure rate from all medically implanted devices anywhere. Estimated 50% of shunts will fail within 2 years, and is a high risk of infection because it's a foreign body being implanted. So it's not great, but we need it. There's endoscopic treatments that sometimes may be appropriate. I'm not going to get into the details. And then there's this other procedure where we're doing it more commonly now, where you can cauterize the choroid plexus to decrease the amount of brain fluid being made, and hopefully what's being made can be absorbed. And these are kids that can get away with treating their hydrocephalus without an implantable device. We still don't use the word cure for hydrocephalus. We never use that word. Okay, so anecdotally, said, there's not much evidence there, but what can reduce the risk of hydrocephalus following hemispherectomy? So disconnective surgeries as opposed to resective surgeries, decreasing blood loss around the time of surgery, decreasing the amount of blood that gets into the ventricular system and causes that inflammation and potentially obstruction, and aggressive drainage of brain fluid following hemispherectomies. Now, if a child were to develop hydrocephalus, what we don't know is, let's say we're going to treat it with a shunt. Where are we going to put the shunt? Are we going to put it in the ventricle side, the normal good side of the brain, or are we going to put it on the cavity side? I'm pretty sure Monica's given me this statistic, but I think 2/3 have it in the cavity side, about 1/3 on the side of the ventricle. And we don't know what's better. Obviously, the cavity side, the pros are that there is no brain on that side that you can hurt, but also these shunts are really made to be in the ventricle, and they obstruct more commonly if they're in the cavity side. This is one of 2 studies published in post-hemispherectomy hydrocephalus. Actually, a pretty good one. So one of our colleagues, Dr. Liu, and a large group looked at post-hemispherectomy hydrocephalus, and they found that about 20 to 30% of patients develop post-hemispherectomy hydrocephalus. However, some of the data here may be flawed because a lot of these patients are from UCLA, and one of the previous surgeons used to prophylactically put in shunts in every patient. And this was when 1986, right? So this is one of some really dated literature now. So when you look at that, the numbers seem a lot higher than they actually are. To be honest with you, when we've looked at our recent numbers, it's closer to 3-5% maybe. So a lot of my colleagues that are doing this now think that the 20-30% is a really over-exaggeration. Not sure a lot of those kids needed shunts to begin with. But once you put in a shunt, that child's shunt dependent. The most common indication to put in a shunt is failure to wean CSF drain. As you can imagine, that can be highly subjective. Do I give a child a chance for 1 day to see if they'll absorb fluid if I challenge the drain and determine they have hydrocephalus? What is the criteria? There's no objectivity when it comes to this. Is headache an indication by itself? So the factors that may be associated from this study are anatomic hemispherectomies, right? So that the initial surgeon, Dr. Peacock, that Dr. Sankar was talking about, would put them routinely postoperatively in these patients. So not surprising that anatomic hemispherectomies, that's when we first started doing these, are associated with higher shunt rates. Whether the deep brain structures, basal ganglia and thalamus, get resected Prior surgery is actually a really important one. The risk of hydrocephalus is cumulative with more surgeries. So when we've had 4 or 5 hemispherectomies, those children almost invariably have shunts. It would be rare not to have a shunt at that point. Things that are unlikely to be associated: postoperative infections, postoperative CSF drainage, and etiology of epilepsy, so what the underlying cause was, which is precisely the opposite of what this next study found, that actually the etiology, the source of what led to the epilepsy, is related. So this is a study out of UCLA, and they found that hemimegalencephaly, children much more likely to have shunts compared to some of the other cortical dysplasia, Rasmussen's encephalitis. As a caveat, I just want to let you know that all these studies that we're talking about with very few patients, we take them as this is the data, this is what it shows. But in scientific literature, studies can be conflicting. Actually, the most popularly cited article in Auto Medicine is why most published medical literature is false. So that's something to keep in mind. Science goes at a very slow speed, and you need to repeat your findings for it to be taken, as fact. Briefly going to talk about brain shift, and Monica talked about brain shift and her son. This can be severe, right? And certain kids, and what we don't know is what is the manifestation of these? Do these kids have headaches? Do they have behavioral problems? Do they have cranial nerve palsies? And we don't know that. But we looked at our 250 children since 1986 that have undergone hemispherectomies at UCLA, 28 anatomics, 222 functional, and that's the shunt probability. But we had an excellent opportunity here. You can't see this, but it shows you that depending on the etiology, the level of brain shift is variable. The children that are most at risk are the ones with strokes. When you actually look at when a shunt is placed, when a shunt's placed in the cavity, those children on average have over 1 centimeter more of a midline shift compared to kids that do not have shunts. And what's worse with the shunts are actually the delta shunts as opposed to the programmable ones, the ones that have a fixed flow every hour. So what do we think we know? That anatomic hemispherectomies lead to a higher likelihood of developing hydrocephalus. We are conflicted as to the evidence whether the underlying etiology may affect the risk. We know repeated surgery increases the risk of hydrocephalus, and failure to wean, the postoperative drain, is the most common presenting sign. But what do we need to know? What is the current prevalence of hydrocephalus? I think it's a lot lower than what's written about in the literature. Number 2, what are the controllable risk factors for developing hydrocephalus? The biggest advancement we can make as clinicians is preventing this in the first place. And can we lower this incidence of hydrocephalus through the establishment of evidence-based protocols? How do we implement these protocols at these centers and see if we can reduce the risk of hydrocephalus? What is the criteria of diagnosing hydrocephalus? We don't have that. Is it clinical? Is it radiographic? Is it ICP monitoring? We don't have that. And when you take your children to 10 different neurosurgeons, you're going to get 10 different responses and 10 different treatment plans. We have no consensus. We only have consensus in the extreme situations when a kid is acutely sick. But other than that, we don't. And lastly, how do we treat it? In this day and age, there's ETVs, CPCs, ways to treat hydrocephalus without a shunt. Now, if we need to put a shunt, where do we put the shunt? What valve do we use? None of this is known. And lastly, how do we measure the patient-important outcomes? The number of shunt surgeries isn't the right outcome to study. It's the development. It's the cognitive outcomes. So our studies currently are focused with the number of surgeries that are required, but that may not be the right question to answer. In conclusion, so hydrocephalus, I think, is one of the most devastating complications following hemispheric surgery, and it actually affects every domain that we have up there: motor outcomes, cognitive, all of the things we talked about. Endocrine, for sure. Research is severely limited. We have 2 articles. One of them is a multi-center study. large, multi-center, hypothesis-driven research is required to address knowledge gaps. Thank you for your time.